This lecture is Andreas Schibler's Physiology of Prone Positioning. But before we turn it over to Andreas, I wanted to acknowledge Andreas in that, again, this is the 301, episode 301, and we're really proud that Andreas is leading off the third season. And he's always supported Ventilation Matters and has provided two of the most watched podcasts. 210 was ventilation distribution during mechanical ventilation. And of course, 206 was electrical impedance tomography, EIT, and mechanical ventilation. And those are two of our most watched series. So thank you, Andres, for all your support. And with that being said, I'd like to turn it over to you.
Okay, thank you, Steve. Okay. For those who do not know me, I'm a pediatric intensivist and a trained pediatric respiratory physician as well. But at the other end of my career, so I'm starting to enjoy the academic side more and more. But I've done more than 30 years of physiology, experimental work, and as well big, large randomized controlled trial in the field of pediatric acute respiratory care. So I'll probably go over and share the screen. So today I have got only 20 slides. They're dense, and I like as well if you interrupt, if you can't follow through what I'm talking about it, because the physiology behind ventilation distribution and lung perfusion is sort of quite complex, and I'm talking about the healthy lung. I'll allude a little bit then as well when we go into the diseased lung. However, what the aim is really to give you an understanding of what normal physiology is, because from there we can then extrapolate into the diseased lung. So, and it's quite interesting, the last 5-6 years, we've gained more insight into the ventilation distribution in healthy subjects. And I'll show you some very new data and good data that explains it, how ventilation works. Okay, now it's very important if we start to understand ventilation distribution that we need to look into the mechanics. The mechanics and the gravity. So we've got these two components or let's talk about it, anatomy versus gravity, because we know that gravity impacts to some extent on ventilation distribution. So we've got the thoracic cage, which is the external framework that holds up the lung inside, and we have the rib, spine and sternum component that pulls basically and expands the cavity. But shall we not forget, a very important part is the diaphragm. I'll later show what the role of the diaphragm and how it operates, but that's the external parts to it. When we look inside the lung, we have obviously lung tissue and mediastinum and the heart that sits within the lung. And if you're in the upright position, as you can see in the upper figure, the diaphragm pulls basically the entire mass of hard lung downwards. In this diagram, the diaphragm is nicely round. However, in the real physiology, as the red line indicates, we have the diaphragm in the posterior part of the chest with a much stronger pull basically onto the lung. And this has an impact if we are in supine position because the abdominal content is pushing the diaphragm cranial and tries to basically impair the expansion of the lung. And that's where the diaphragmatic pull in the posterior part becomes very important. And why do we have this diaphragm in that type of position and not in a position like the upper figure is showing, like a nice round dome? this is evolution, because in principle, our diaphragm is still a diaphragm that has been built for walking on four legs. So that's why we still have a diaphragm that's not necessarily ideal for supine position. And now this is the first hint to its prone position. So if we go into prone position, we go back into the original intended position of the diaphragm in four-legged walking. So the diaphragm doesn't operate necessarily as a unique and homogeneous structure. It pulls much more in the posterior part of the lung. Okay, so we need to keep that in mind, that during normal breath, the diaphragm is pulling more in the dorsal aspects of the chest. And now you can imagine that's probably where more volume change is going to occur. So we need to have very clear definitions of what we're talking about, and we need to be very clear in what we talk when we talk about lung volume, perfusion, etc. If we talk about lung volume, we talk about a static set of lung aeration at a given stage of the respiratory cycle. Most likely we talk about the FRC, that's at the end of an expiration. So that's the end expiratory lung volume. Lung ventilation, however, is where the breath that we inhale is distributed to. So we're talking about lung ventilation is different to lung volume. So they're two different entities. And lung perfusion is where the blood is distributed within the lung in the different lung region. And obviously, lung perfusion is pulsatile, much less pulsatile than the arterial blood volume that we distribute, because the resistance is very low in the lung, the blood pressure is very low. So it's much more a static type of blood volume change that has much less pulsatility within the lung. And that's the lung perfusion. So these three different definitions are very important, and we need to be very clear when we talk about it. Now, this slide shows that the static lung volume is dependent on gravity or the way we are positioning ourselves. It shows, for instance, if you have a subject in right lateral position, that means the left side is up, and you measure the lung volume, that's the static volume at end expiration. In the right lateral position, so left side up, the lung volume is greater in the right side compared to the left lung. And if you turn over on the other side, you have the opposite. So you have a change in the distribution in lung volume. Now, this is a very old paper from Sylvain Burbank in Belgium, where they showed where the volume distribution occurs. So if you look at this on the right-hand side in panel B, these bubbles represent the static lung volume. You have greater lung volume in the upper part of the lung, and you have a lower lung volume in the lower part at end expiration. However, if you then perform a slow inspiration to total lung capacity, that's on the left side, you can see the volume change that occurs is higher in the dependent, so the lower parts of the lung. So that's where most of our ventilation is distributed. And I'm talking ventilation, that's volume change, is going into the dependent parts of the lung. Whereas the upper part of the lung does have some change, but much less compared to the lower. So when we inhale, most of the volume that we inhale is actually going into the dependent lung. So that's the normal physiology of an adult standing upright. And Milik Emily showed as well quite nicely that we have these three different lung zones, the upper, middle, and lower part of the lung. You can see that the so-called uptake of air is mostly occurring in the lower part. So on the right panel there, you can see the so-called volume change in comparison to the TLC is initially slow and picks up very quickly, and we have much more lung volume change in the lower parts of the lungs. And this is more or less an accepted philosophy behind the ventilation distribution in healthy lungs. Interestingly, as well, as I showed in the first slide, is that if you measure FRC, if we are lying down or have even a Trendelenburg position, like on the left side, so legs up, head down, you can see that the FRC is small, and that's obvious. The abdomen is pushing basically downwards. When we go in normal supine position, it increases slightly, and the more we get upright, the more lung volume we have available for breathing. I mean, that's very simple lung physiology that should be obvious to most of us. Now, with newer imaging technology using MRI, we can actually visualize the ventilation quite nicely, and most of the scanners have now the capacity to measure lung volume, so air inside the lung, and we may as well be we are as well in the position to measure lung perfusion. If you look now at the upper panel, that's an inspiration from residual volume FRC to TLC, and blue means better aeration, and red means more so-called collapsed or less or denser lung tissue. And you can nicely see how the lung volume starts to increase from residual volume to TLC. However, the remarkable change that you can see in the dorsal aspect of the lung from red to nice bright blue. So you can see that most of the volume change during a slow inhalation from residual volume to TLC is occurring indeed in the posterior aspect or in the dependent aspects of the lung. If we look at the perfusion, however, and perform the same experiment breathing in from residual volume to TLC, there's not much change in the perfusion. So perfusion has, if we simplify it, almost no effect in the way it's being distributed if we have a slow breath from residual volume to TLC. It's still sort of homogeneous distributed within the lung. So we have ventilation that is hugely changing, perfusion that doesn't change that much. So we have these two components. And as you know, we want to match ventilation with perfusion, ideally. We want to have the lung that's well ventilated as well perfused. And so the ideal ventilation perfusion relationship is a 1 relationship where the ratio is equal 1. And you can now imagine that if we depending on the where we are in the respiratory cycle, the ventilation perfusion mismatch or match may change over time quite dramatically. Here is another description of the ventilation distribution in the upper graph, and on the left lower we have the perfusion and then the ventilation perfusion ratio. Now, just pay attention to the red, that's the supine, and the blue is the prone. So if we look at a ventilation from cranial, so that's from the top down to the diaphragm in the direction, you see that on the very top and the very low part of the graph, the ventilation is sort of a little bit tailored off. But if we are in prone or supine, it doesn't make a big difference if you look at this graph here, and that's tidal breathing. That's tidal breathing. That's not anymore from residual volume to TLC. So during tidal breathing, you're doing okay in the ventilation distribution, not much difference seen here in this between supine and prone. Interestingly is, however, if we look then at the perfusion again, not much difference between ventilation and perfusion. However, if you compare it to the maroon or orange upright graph, you can see the perfusion has a huge difference. If we look at from cranial to caudal, that means the blood sits down in the lung. And you can imagine a fluid wants to sit down using the gravity against basically the perfusion. And as you can see, the ventilation-perfusion relationship, if you plot it on the right lower graph C, you can see between prone and supine, we can't detect huge differences, whereas when we look at the VQ mismatch in upright position, there's quite a remarkable difference between the upper aspects of the lung versus the caudal aspect of the lung. Okay, so that means in the so-called cranial caudal axis, prone supine, we can't find a difference. But as soon as we go into the upright position, we start seeing differences, and that's just a description of the gravity as having an impact on the ventilation or perfusion distribution, or if you take both of them together in the VQ ratio. We've done quite a while ago a simple experiment, placing healthy subject in right and left lateral position. So on the left-hand side is the right lateral position. That means right side down, and the left side up. Okay, and we measure the lung volume. And as you can see, a volume change again. So where is the volume going in? Where is the volume happening? So if you position a patient in right lateral position, the right side is down, the left side is up. And when you inhale, most of the air is actually going into the right side of the chest in the dependent lung. As you can see, this right colored red area is the image that you get from EIT. EIT is measuring lung volume changes. So that means the dependent lung is better ventilated than the non-dependent lung. And as a proof of concept, if you flip the subject around, put left side down, you see exactly the opposite, that the left lung becomes the better ventilated because the left lung becomes the dependent lung. So with the EIT, we have a tool that tells us during spontaneous breathing, and you can use it obviously as well during mechanical ventilation, where you direct your breath that you deliver or you inhale, where you direct your breath to. Now, of course, in a diseased lung, if you have the dependent lung full of gunk and pus and secretion, won't go in there. You will see in an EIT image that instead of going into the right side, if right side is down, everything goes into the left side if you have a patient in lateral position. So that just demonstrates we have tools available that can measure bedside where you're distributing your ventilation to, but the tool will help as well if you change the position. Does the position change have an impact where you distribute your lung ventilation to? Okay, does that make sense? Now, EIT helps us as well to differentiate between lung ventilation and lung perfusion. Ventilation is happening, let's say, at 20 breaths a minute, and the heart is beating at 60. In that middle graph, you can see the frequency spectrum of the above EIT signal, and you can see two peaks, one peak just below 20 cycles per minute, and then you see this minuscule peak around 65, 70. That's a frequency coming from the heart. And you can see in the upper panel as well that the signal has these little notches. The respiratory cycle has these little notches, and that's due to the cardiac impulse or the perfusion into the lung. And if you separate now in a mathematical way the two signals, you can see in the lower panel, the lung ventilation on the left side. These are the left and the right lung, like a CT scan, cross-sectional image of the lung. And you can see the lung perfusion on the right-hand side. And the big red thing in the anterior part of the chest is the heart, because the heart is the big contractile element inside the chest that you can actually see the heart beating in there. Now, if you then look at how the perfusion is happening during the respiratory cycle, the upper panel shows this blue, we call it ROI lung. This is the respiratory cycle that you can see. And again, you can estimate a little bit these notches that are occurring from the cardiac impulse. Then the black line is the normal ECG. So that's the heart beat, obviously. And then you can see the red signal, which is the lung perfusion signal. And you can see that this is slightly followed later after the ECG QRS complex. So we have this time delay between the electric impulse and then the perfusion into the lung. So the red shows the heartbeat, the blue one shows the lung perfusion, how basically it's not completely in synchrony. The heart beats first and then the lung is perfused thereafterwards. So we can separate that. And what we've done is now showing what happens with the ventilation, which is the upper two panels. What happens with the perfusion is the middle two panels, and the VQ match is the lower panel. And we placed healthy subject in prone and in supine. Now you can see that ventilation, again, like before, ventilation goes into the dependent and more likely than in the non-dependent part of the lung. Now in supine position, you can see the dependent part is a greater signal compared to the non-dependent. Whereas in prone, we can't really prove the same, can't we? Because we would expect as well a similar behavior between non-dependent and dependent. So sort of in prone position, gravity change or position change doesn't affect it that much. So could it be the diaphragm actually that is the culprit for it? And remember again, the diaphragm is pulling much more in the posterior aspects of the lung. So gravity may not place as such a big importance on ventilation distribution. It's probably the diaphragm and the position of the diaphragm that has a much greater impact. And it's as well, gravity is, let's say, 30, 40 centimeters wide in the anterior to posterior aspects, where in upright position from cranial to caudal, we've got almost 80 centimeters of gravity that impacts on it. Now the perfusion, you can look again in the middle graph, there's not much difference between ventilation and perfusion. Perfusion is not much different between prone and supine. Like I showed in the MRI picture, there's not much gravity-dependent distribution changes happening between prone and supine. So if you then look at the VQ mismatch, we get the obvious differences, particularly in supine and prone, because perfusion doesn't change, ventilation change a bit, so obviously VQ mismatch or change needs to occur. So what that means is that ventilation is probably more driven by anatomy in prone position. And the reason is because the diaphragm has a much more active role in the way the lung is ventilated in prone position compared to supine. Now, I'm leading you in a in very sophisticated lung imaging using SPECT, which means that we use radio-labeled traces, and we use radio-labeled traces that we inhale, and we use radio-labeled traces that we inject. So we get the inhaled traces. They will go where the ventilation is best during the inhalation phase. And during the perfusion phase, the tracer will be deposited in the lung where the perfusion goes during ventilation. So you can imagine we have traces that are indicating where the ventilation is distributed during the inhalation. And we've got, at the same time, we've got traces. They're telling us where the perfusion sits. And we can separate these two traces and can generate images for ventilation. We can generate images for perfusion. And now you can imagine that depending on where these traces are going, you have a lighter signal where you have more deposition of a tracer during the inhalation phase, or you have more of the perfusion traces depending on where the perfusion is going to. Okay? Now, you can administer the tracer in supine position, or you can administer the tracer during prone position. So you have to do 2 experiments, and you have to do them 48 hours apart. So you do the first experiment in supine position, and you're interested, where is my tracer, the inhaled tracer going? And where is the perfusion tracer going? Then you have to wait 48 hours because you have to wash out all the tracer. You repeat the experiment and inhale the tracer in prone position. That's the lower panel. And then we can play afterwards by imaging in prone or in supine position. Okay, so these are 2 experiments, 48 hours apart, where we have the tracer delivered in supine, or we have the tracer delivered in prone. And remember, there's an inhalation tracer or there's a perfusion tracer. Okay? Now, here you can see at the perfusion on the left side and the ventilation on the right side. Okay. So, in the upper panel on the right-hand side, the tracer has been administered in supine position. So if you supine, we would expect that the so-called dorsal aspects of the lung are better ventilated, or the tracer is going into these aspects. And indeed, you can see the red color is more in the dependent lung if we image in supine. Okay, does make sense. That's what we've just talked about before. The dependent lung is better ventilated. And you can see that if you place a patient then in prone, that sort of there's a shift happening of this lung tissue moving more towards the sternum. Okay? You can see as well this distribution. Or we have now the opposite. We have the tracer given in prone position. Okay? And we image the patient in supine. Interestingly, again, the tracer sits in the dorsal dependent area more. So we can see that sort of the lung tissue plays quite an important role. And we know lung tissue is quite movable within the chest, and the gravity has quite a significant aspect on it. Now, with the perfusion on the left-hand side, again, the tracer is administered in supine position. And you can see that the tracer as well goes more in the dorsal aspect. And again, the gravity has an impact where the perfusion is going to. And if we flip the patient now into prone position, you see how homogeneous the perfusion gets. And now remember that the perfusion gets very homogeneous once we are in prone position, even if we have delivered the tracer in supine. So that means that, in other words, we have lung tissue, when you flip the patient around, ventilation is gravity dependent and is dependent as well in what position you are, and you're more likely, like we show on the right-hand side, ventilation goes into the dependent parts of the lung. Now, with the perfusion, it is not that much so if we are in prone position. In prone position, we all of a sudden get a much more homogeneous distribution of the perfusion. So if people are asking, what is it, what makes a big difference, or where are differences coming from, is probably because prone position allows a much more homogeneous distribution of the perfusion. So I'm not going into the lower part, into the prone position, because it's exactly the reverse of what we just talked about. So if you deliver the gas in prone position and repeat the same exercise, you will see just the reverse of what we discussed. Okay? Now, more important is what is happening during mechanical ventilation. Because during mechanical ventilation, we upset the normal physiology of the lung and the ventilation and the perfusion. And these experiments, they've done that in 6 or 8 healthy subjects. And what they did, they were anesthetizing these subjects and were paralyzing them. And they've been ventilated and paralyzed and obviously sedated and anesthetized as well for the experiment. But they repeated exactly the same experiment before. So they performed, again, a series of experiments. They induced these patients either at 0 or 10 PEEP in prone or in supine position. Okay? And then they delivered as well the tracer gas either at 10 or 0 PEEP. So the question was, where is the volume inhaled going if we have 0 PEEP, or where is the volume going if we have 10 PEEP? And what's the impact of the position when we deliver again 0 or 10 PEEP in prone position? So they were asking, what happens when we paralyze and we don't have the diaphragm as the pulling mechanism, because the diaphragm is now passive and we are pushing air into the lungs. So we don't get the dorsal pull of the diaphragm. Okay, where is the air going to? Now, this graph basically summarizes it. And I'm talking you through. Okay, first of all, we have ventilation in supine. Okay? Patient is in supine position. And we have 0 PEEP. And if you look from dorsal to ventral, that's the blue line now that we're looking at, you remember it looks pretty much similar to what I've shown in one of the first graphs. Okay? So the ventilation is sort of not that great in the dorsal, not that great in the ventral. That's the so-called expanded lung. That's where not much ventilation is happening. But it's sort of, yeah, homogeneous distributed, isn't it? If we then apply PEEP, it looks very different. The ventilation now all of a sudden wants to go into the dorsal aspect compared to 0 PEEP. And why is that? The reason is PEEP pushed the diaphragm downwards or towards the abdomen. And you can see the red compared to the blue, where the ventilation is much more in the dorsal aspects of the lung. Okay, so what 10 of PEEP does is splinting the diaphragm to a lower position, and the splinting of the diaphragm occurs most in the dorsal position. Does that make sense? Okay. Now, let's look at the ventilation in prone on the right upper graph. 0 PEEP, again, is the green line, and no 10 PEEP is the yellow line. And you can see now that the ventilation between 0 and 10 PEEP looks similar. Now the graph, unfortunately, the way they published it, has a different direction. You know, you see that the ventral is on the left side of the graph in the right panel, and you see the ventral is on the right side of the graph in the left upper panel. So you can see that the two of them in prone position, 0 PEEP and 10 PEEP, they look sort of similar to the blue one on the left-hand side. Okay, does that make sense? So that means the effect of PEEP in change in ventilation in supine position, that's on the upper left side, is huge. That's the red and the blue one. Where the effect of PEEP in prone position doesn't make a big difference. Okay, now I'm opening here a bracket, and you may have heard that people say we need much less PEEP if we have patients in prone to achieve the same oxygenation during the COVID ARDS ventilation. There's several papers out there. They say they can achieve in prone position the same ventilation with less PEEP. And now you can see why this is occurring. It is because in supine position, you have to splint the diaphragm into the right position, where in prone, you get you need much less splinting effect of the diaphragm. And you can achieve that splinting effect and ventilation distribution with less PEEP. Does that make sense? So if we observe during disease that we need less PEEP in prone position, it is due to the configuration in the chest, most likely due to the position of the diaphragm. Now let's look at, so that's the gravity aspect of it, okay? Now we can do now several permutations of the same. I just want to highlight, it doesn't really matter if we image someone in supine or in prone position. If you look at the, let's go to the left lower graph and the upper right graph, and just look at the green curve. They're similar, aren't they? They have exactly the same shape. That means when we have an imaging done, independent of how we have delivered the tracer gas, the position that we are in is most determined of where the ventilation distribution is going. And it is the position of the diaphragm that is basically the culprit of where the ventilation is going to. So we have gravity aspects. We know that the dependent lung is better ventilated, but we have as well effects of the anatomy, and the anatomy is here during mechanical ventilation, the position of the diaphragm. Or, as I said initially, it all depends on what we have inside the chest, how we configure the tissue, the heart, the mediastinum, and the lung and the diaphragm within the chest. So in normal physiology, we keep having the perfusion sort of not that much gravity dependent, whereas the ventilation is or can be manually manipulated with gravity. In dependent lung, better ventilation than the non-dependent. But as soon as we start to paralyze a patient, the whole paradigm of gravity-dependent ventilation is thrown out, because the position of the diaphragm or the configuration within the chest is much stronger or much more determining where the ventilation is distributed. And for those who are familiar with very old paper, they described in ventilated patients. Yeah. So, someone a question? No, okay, sorry. So if you look at the 30, 40 years ago, Milik Emily as well described that during paralysis and mechanical ventilation, we have the reverse of normal ventilation. So normal ventilation is dependent lung is better ventilation than the non-dependent, or the upper versus the lower. And during mechanical ventilation, we flip that actually around, because we lose the configuration within the chest if someone is paralyzed. And that opens a lot of questions. What is the role of paralysis? Should we paralyze? Yes, no, because we're gonna basically screw the normal ventilation distribution. How much PEEP do we need to apply to reverse that pattern, as you can see in the upper left panel? So you see that as soon as we start interacting with the normal physiology, we get very quickly the impact of the tissue distribution within the chest. Now, the perfusion is the other one. So we would assume, okay, perfusion shouldn't be affected as much by PEEP. You would probably agree, because we said perfusion is much more homogeneous distributed, depending on the gravity. Now look at, again, the upper left graph. You can see the green line is zero PEEP. Most of the perfusion, as we have described before, heavy blood, more likely to go into the dependent, but it's not as much gravity dependent. You can see the PEEP all of a sudden opens up the dependent lung. And once we have opened up lung, we get a better perfusion. So you see the blue line, which shows quite a remarkable increase in perfusion into the dependent lung. So if we combine now ventilation and perfusion, as soon as we start opening parts of the lung, we get a redirection of perfusion into these parts, because the resistance or the hypoxic vasoconstriction within these areas is reduced, and we're going to have likely a better perfusion. But it follows as well the gravity on top of it. And now on the right upper panel, again, if you look in prone position, we have the red line is 10 PEEP and the yellow line is 0 PEEP. You can see 0 PEEP, the perfusion, again, not much, you know, I shouldn't call it homogeneous, but you see the effect that you get from 0 to 10 PEEP in prone position. Again, how the lung gets pushed down, and now obviously as well in the dependent part or in the ventral part of the lung. So you can see that we have first the ventilation that is going to change and the perfusion will follow. Okay. I'm not going too much into the lower two graphs. I mean, you can make your own assumption if you look at these different regional perfusion images or perfusion states. But quite interesting, if you look at the right lower graph, and particularly the blue graph as well, and if you carefully watch the right lower blue graph and compare it to the left upper blue graph, they're just the mirror image. So it doesn't matter where and how you image, the perfusion remains the same. So if you put or get the imaging done in different positions, doesn't matter. It is more ventilation distribution related, where the blood as well will follow. So in other words, to demonstrate the following is that without measurement where the lung volume indeed is going, we can't predict necessarily if we have a paralyzed and ventilated patient, if we don't have a clear definition of the ventilation distribution. And you can see that an addition of 10 PEEP is completely throwing the ventilation distribution. And it is, of course, position dependent, but you see the effect of PEEP is huge. So if we talk about prone position, we need to talk about PEEP at the same time as well. So it's not just that prone position in its own is improving the perfusion or the ventilation perfusion relationship, it is as well PEEP dependent. So there's much more work to be done in disease if we want to have a relationship between ventilation and perfusion, because the third factor that's coming in there that we need to consider is the PEEP that we apply. So it gets quite complicated. We have a position-dependent ventilation distribution. We have a position-dependent perfusion of the lung, but we have as well a PEEP dependency. And now you can imagine that within an individual patient who has consolidation in certain parts of the lung, that may be on the right side, on the left side, or in the anterior aspect or in the posterior aspect. Most of the ARDS patients have very consolidated lung in the dependent part of the lung. And that's why we put them from supine to prone. But the reason why they're improving from supine to prone is because we're shifting the lung tissue within the chest. We're shifting the perfusion as well within the chest. And we're shifting as well the effect of PEEP inside the chest. So it's not a simple one-for-all recipe that we can say in prone position, you will automatically get better, but it is as well dependent on what PEEP you are applying. And reports have said that they were surprised that they need less PEEP in prone position, which is simply explained by the configuration of the chest, the configuration of the diaphragm, or the splinting of the diaphragm. That needs less pressure to be splinted if you're in prone position. Or in other words, if you're in prone position, your diaphragm, even during spontaneous breathing, is much more efficient because it's the dorsal aspect that has the greatest pull. And if you have great pull on the diaphragm, you have a lot of volume change, which is happening then if you're in prone position in the dorsal aspects, in the diseased patient, and you get better ventilation. So without having tools in your hands that is measuring ventilation distribution, you basically can't predict how the ventilation distribution and the perfusion will improve. And I'm just taking you back to the image here. We have a tool that is bedside. We have a tool that can tell you where the ventilation is actually ventilated or distributed into. So we can't necessarily in a diseased lung predict where the ventilation is distributed. We need to go back and measure it. And without measurement or imaging of it, we not necessarily know what we can achieve. And we still depend on very crude assessment by blood gases, PF ratios, etc. When we look at does prone actually improve? Yes, no. Does PEEP improve? Yes, no. We should apply and use imaging technology that tells us actually the change that we observe in between two different positions. And we have with EIT as well imaging technology that tells us where the perfusion is going to. We can actually tell as well where ventilation is distributed and where lung perfusion is distributed. Unfortunately, the ventilation companies and the imaging companies still haven't taken up the call for cheaper, easier technology. But without these tools, we can't fully predict where ventilation is distributed. So in summary, blood flow is greater in the dependent lung. an addition of PEEP increases that effect, which is logic, because PEEP does splint the diaphragm and opens up more of the dependent lung. And that's what we know. Prone ventilation is distributed dorsal. When we have, again, the change in position, addition of PEEP doesn't make a big difference. So that's why we don't need as much PEEP in prone position. And in supine ventilation, PEEP shifts quite significantly because that's the diaphragmatic splint that we expect. So PEEP has a huge effect in supine position. But you know that the VQ mismatch is increased in prone initially because we open up lung that's not yet perfused. So we see a ventilation perfusion mismatch, but that doesn't necessarily apply in the diseased lung. In the diseased lung, we have to image it. And without, we can't tell exactly what's happening within the lung. Now, so I hope that I have confused you guys completely, but I encourage you to go through the last 2 slides and basically go one region after the next and try to make sense. Because I myself have, every time I'm talking about it, have to very carefully start to have an understanding what the effect of PEEP is on the diaphragm and what the effect of the position is on the gravity of ventilation distribution or perfusion distribution. So these last 2 graphs, I think they are the pinnacle of normal lung physiology. They explain where perfusion is going, where ventilation is going, and where the impact mostly is if you're using 0 PEEP or 10. So I'm happy to answer some questions from here, and I hope you enjoyed this quite complex topic.
Thank you, Andreas. As always, it's a pleasure to listen to your presentation. And if anyone has any questions, please. I have a question for the group, which is, are you proning much? Is there a lot of proning going on? I've read some publications where it sat around 20%. Also, I've read some of the meta-analysis done by Beitler and Mohatra from UCSD, where they were looking at mortality relationships and proning. And the meta-analysis showed that when it was stratified with low tidal volume activity and perhaps even more attention to mechanical ventilation, that there seemed to be a reduced risk in a reduced rate of death. And so with that, do we have any questions? I know it's also, there's also literature in the application of spontaneously breathing patients on ECMO. And we have Matt here, which would be a great question to ask Matt. Do you prone your patients?
Prone our patients, yeah, so there's a tendency in our ICU to prone patients when they've met ARDS criteria and when their PF ratio is less than 150 after being paralyzed. We do generally see that there's improvement in the PF ratio. I'm still trying to process my understanding of that, because my understanding had always been that we get better sort of more homogeneous recruitment of the lung when they're proned. And I'm trying to reconcile whether that's been a misunderstanding with the data we've just seen. But that understanding had come, or that sort of perception had come from the fact that we're able to wean the PEEP once we prone the patient. But I think what I'm seeing now is that actually there's a lot more going on than just simple recruitment, probably because of the change in perfusion as well that's happening. But I'm still trying to get my head around some of those graphs. Is it true, Andreas, that from some of that data that when we prone our patient, we do get a more homogeneous sort of recruitment of the lung, in that I suppose there's just less dependent parts when we shift position, so we don't need PEEP in the same way. Is that a misunderstanding, or?
No, not at all. The difficulty is that in trying to understand the impact of prone position in an ARDS patient is because we have several factors that are impacting on the ventilation distribution. So one factor is we have gravity that impacts on it. The second factor is, let's phrase it. You place someone from supine into prone, okay? What are the different lung regions experiencing? So if we place someone from supine into prone, we know that the so-called posterior aspects of the lung in supine were the messy ones. They were full of secretion. So you start with less well ventilated dorsal aspect, and now you start to put them upwards. And so you get automatically more lung volume all of a sudden in the dorsal aspects of the lung, okay? Because they start to aerate. So not talking about the diaphragm yet, not talking about anything else of PEEP, etc. It is just the fact that you turn the lung upside down and you get a gravity pull in the lung areas that were poorly ventilated and aerated. And it's more the aeration that we're talking about. Okay? So you get all of a sudden more lung volume available to be ventilated. Okay? So you improve the ventilation because of disease-related processes in the dorsal aspects that become better ventilated. Okay. That's what you see in the oxygen tension increase in the blood, because you get more lung volume contributing to the gas exchange. And as I showed before, perfusion, if we look at perfusion in supine position from dorsal to anterior, or from posterior to anterior, there's not much change that occurs, gravity dependent. So that means the perfusion remains the same, the ventilation gets better if we flip them around. And so you automatically get a better VQ relationship in your posterior aspects of the lung if you position someone in prone. So that's one aspect why the observed gas exchange is improving. Okay? The other aspect is now what is happening with the diaphragmatic function. Let's say you have a spontaneous breathing patient. The diaphragm is pulling in the supine position posteriorly, but can't ventilate because the lung is collapsed there. Okay, so the diaphragm can work as hard as the diaphragm wants to work, but we don't see much volume change in the dorsal aspect if you lie supine. Okay, now you start flipping the patient around. The diaphragm is in a much more powerful position now to help the improved aeration of the posterior aspects of the lung. So you get an additional positive effect by having someone spontaneously breathing in prone position. Okay, so you get a better aeration and you get a better volume change in the posterior aspect. Remember I said we need to look at volume and we need to look at ventilation. So if we flip a paralyzed diaphragm from supine to prone, we still get more lung volume in the posterior aspect. But if we look at even spontaneous ventilated patient, we get a greater function of the diaphragm by turning them around from supine to prone. We get a better ventilation as well occurring in the posterior aspect. And now we need to look at what is the effect of PEEP. And as we said, that PEEP as well splints the diaphragm in a certain position. And so 0 PEEP and 10 PEEP has a very different effect, where PEEP of 10 pushes the diaphragm down and gives a better aeration. And where would you expect the best effect of PEEP? Of course, in supine position, because that's where you have most of the volume that you can improve in the posterior aspects. Whereas if you flip the patient around and you push as well 10 PEEP to the posterior aspects, the position has already helped having a better position of the diaphragm and effect of the diaphragm. So that's why PEEP has less huge impact on the change in prone position compared to supine. You don't need that much PEEP in prone position. Does that make sense?
Yeah.
And the perfusion, to simplify it, the perfusion is not that much affected with PEEP in that axis from posterior to anterior. So if you have someone in prone or supine, yes, it does, but not as much. PEEP has as well an effect on perfusion. As soon as you get lung open, the perfusion goes in. So they go a little bit hand in hand, but you get less effect of the PEEP in the different positions, but the ventilation has a huge impact. And that's why some are advocating and say, look, let's keep patients, if we can, from gas exchange allowing, them in prone position and give them a little bit of PEEP with high flow or non-invasive ventilation, but keep them spontaneously breathing, because we get a little bit of PEEP effect in prone position that helps, and we've got the help of the diaphragm to make sure that these dorsal aspects of the lung are better ventilated. And that improves your gas exchange. And of course, if you have someone paralyzed and ventilated, you completely rely on PEEP. You completely rely on, the ventilation distribution, but it only works. It only works if the, let's say, posterior aspect of the lung can be re-recruited by this position change from supine to prone. And so that makes your gas exchange better. And that explains as well that clinicians describe we need less PEEP to achieve the same PF ratio in prone position compared to supine. So in the end, without proper imaging bedside, we're speculating that's what's happening. We know from these extensive CT scans that Gattinoni did that this is probably what's happening. But in an individual patient, you can only speculate probably that's what is improving the gas exchange. And the big question is spontaneous breathing, yes or no? We have all the data says 48 hours of paralysis and mortality, etc., etc., etc. I think it becomes very complicated because there are other factors that are playing a role. We quite commonly forget as well that if you paralyze someone, you reduce the oxygen demand roughly by 20 to 30%, because you don't have the respiratory function or the respiratory muscles contributing to the oxygen consumption. And so is that the reason why paralysis improves in certain outcomes? Is because we reduce the oxygen demand, so we don't need to deliver as much oxygen. Is that just what we observe? Because paralysis doesn't necessarily improve ventilation distribution. It makes it worse. But there's many questions open, and we're still completely fishing in the dark. But I hope that sort of helps a little bit the understanding what you're saying, that you believe that VQ distribution is better in prone position, and that's the reason why it's better.
Do we think that, because obviously during COVID there's been a lot of practice of non-ventilated patients just on high flow being put in the prone position, awake, spontaneously breathing patients, and do you think the mechanism of disease with COVID, with the sort of pulmonary endotheliitis, if that magnified the effect of proning in these patients, perhaps because of the loss of hypoxic vasoconstriction?
Absolutely. I think the hypoxic vasoconstriction is another player in the equation, and the effect of the hypoxic vasoconstriction is certainly unknown. If it is reversed by position change in certain lung areas, yes, no. And if you then have a hugely inflammatory process like in the COVID ARDS, it's an unknown how that impacts again on the ventilation distribution. And the COVID ARDS is probably a lesser affects probably less congestion inside the chest than the regular ARDS. So probably this effect needs to be further investigated. We simply don't have any means to measure it. Yeah. But maintaining spontaneous breathing and seeing if we can improve the ventilation distribution by position may be the key to it. But then be mindful, for instance, if you have an obese patient, the way you prone is not necessarily the right way to prone. So if you have the abdominal compartment pushing against the chest, and if you don't use a prone position where you have the belly offloaded, you may reverse that whole effect again. Mm-hmm. These healthy subjects, they were all mean, lean, young adults, so it's not necessarily what you see in your ICU.
Yeah.
Any other questions?
So I think the other thing that I think you've alluded to in physiology talk that probably doesn't just apply to proning and supine is the determinants we're using to measure have we got our PEEP right. The PF ratio is probably not a very good measure of whether our PEEP is right, because there's so many other things it's affecting than just simply the PF ratio. Because I've worried about this actually in COVID more and more is as some of the early COVID patients, like you say, their compliance isn't horrible, but their oxygenation can be. And if we chase that with PEEP, we sometimes then create a situation where the compliance eventually does become bad because we've been exposing the airways to too high airway pressure.
And you're alluding exactly to what prone position probably has indirectly helped to reduce that effect, because let's assume you have a quite significantly hypoxic patient that you paralyze and ventilate in supine position, and to get your ventilation distributed or assumed ventilation, improvement ventilation in the posterior aspect, you need quite a lot of PEEP to counteract that. And you may indeed over-distend the lung that doesn't need to be over distended, because it is another process that causes the hypoxemia. And if you place then this patient into a prone position, you get a much more favorable distribution of your PEEP, where you need less PEEP to splint your diaphragm. And so this observation that you need less PEEP for the same PF ratio in prone position is probably purely related to the configuration of your chest, to the configuration of your diaphragm, and how that is positioned. So you may observe a protective effect of prone position, that the clinician uses less PEEP, and your concerns are, addressed in that sense.
So in many ways, because the benefits are, we have a tendency to, I think, over focus on oxygen, and we forget that the lungs are also clearing CO2, right? So if we were to think about measures more in terms of what's happening with the CO2, or what's the effect of our changes on the dead space, if we were looking at those as well as purely the oxygenation, perhaps we'd be setting our ventilators up or putting the patients in the right position more effectively. Do you think we're probably not looking at a broad enough numbers, or I suppose EIT and lung perfusion would are kind of measuring similar things to what dead space would be looking at?
It's absolutely correct. I mean, the relationship between dead space and mortality has been quite nicely shown, and dead space will hugely be affected by position, because we completely reverse some of these relationships. And we may, particularly if you go from supine in prone position, you get an improved ventilation of the posterior aspects of the lung. Your dead space will decrease, and you need less tidal volume size. And if you talk about less tidal volume, you need less pressure to ventilate, or less power in that sense than to ventilate the lung. So it's all interrelated, and it's true. It needs the expert bedside to take all these elements of the equation together, and that's why it's so difficult to achieve, ideal ventilation.
Yeah, my choice would be if we could measure heterogeneity or homogeneity of ventilation in relationship to our application of ventilation, and then if we could at the same time also see effective pulmonary perfusion coupled with effective ventilation, then we would really have a onboard VQ system. And then, of course, using EIT, we could understand exactly where we're headed as well. So that's the hope of the future, I think. And it's not too far off, I hope. Well, I want to thank everyone for joining us. I appreciate everyone attending. We had a great showing, and thank you, Andres, again for a wonderful presentation and discussion thereafter.
Thanks. Great talk, Andres.
Okay, thank you.
Everyone, breathe easy.
Okay, thanks. See you.
Take care.